Yes, Scott.
As promised before lunch, I'm going to turn to treatment. But before I do, I just want to make a comment, really, by way of explanation, both to the panel and to those that are listening, particularly for those that weren't here yesterday. And that's just to say that in your report, you were asked to and have provided a short chronology of key events, and consistent with the approach that's been taken with other expert groups, I am not going to ask you what was or should have been known by clinicians during the first half of the 1980s about risks of HIV or HTLV3 or AIDS, and I'm not going to ask you about medical and scientific work being done then in relation to the virus or to the development of a test for what we now know as HIV. And the reasons for that is because it is a question of fact for the inquiry, which the inquiry is investigating by reference to contemporaneous material. And so those questions, any questions in relation to that, will not form part of what happens for the rest of this afternoon.
And I should add, in relation to the evidence of those who can give their own contemporaneous testimony.
Indeed. Moving then on to the treatment for HIV itself. We've touched on treatment for some of the AIDS-defining conditions, but moving on to the treatment for HIV itself. Can somebody give us a brief outline of the first generation treatments, the monotherapies?
Look to Ian for
that's
that.
fine. The first therapies basically targeted a particular enzyme in the virus replication cycle called reverse transcriptase. So reverse transcriptase were responsible for manufacturing a double-stranded DNA copy from a single-stranded RNA copy in the infected T cell. And so it's an enzyme that was encoded by the virus to be able to do that. Okay? And so what the initial first-generation drugs, the nucleoside reverse transcriptase inhibitors, targeted that enzyme by basically binding to the active site of that enzyme and inserting into the elongating DNA chain and terminating it. Right. So that's the way it worked. Now, the first drugs were a drug like AZT or azidothymidine, now called zidovudine, which wasn't developed specifically for HIV, but came off the shelf. It was actually a previous drug that had been tested for cancer, but it had been known to have an effect on being able to stop the reverse transcriptase enzyme. And so that was originally made available in the UK in mid-1987, following the results of a trial in the United States, which looked at giving patients who already had AIDS or severe disease zidovudine. And the trial was stopped after a few months because there was a much higher mortality in those who didn't receive the drug compared to those who did. So the mortality fell from 14% down to 1%. In fact, there were 19 deaths in the control arm and only one death in there. And on the basis of that, zidovudine was licensed, right, as something that would be able to reduce or improve mortality. The problem with zidovudine monotherapy is that at the time we didn't have the same knowledge of the virus as we do now, but it became apparent that the clinical benefit of that was short-lived. It was, and it came at a high cost of toxicity in terms of side effects. The dose that was used in the early trials was twice the dose that is now licensed for it to be used. And so, yes, there was a desperate need to try and develop drugs and get treatments out there, and this was made available. But it was by far, it was a drug that really was not fit for purpose in terms of being able to deliver what we wanted to achieve. And there were other nucleoside reverse transcriptase inhibitors that became available in the early 1990s. That included zalcitabine or DDC or didanosine, DDI, and stavudine D4T. And they all worked in the same way in that they basically inhibited this enzyme in the virus needed to be able to infect a T cell and for it to replicate itself within the activated T cell. All these D drugs, as they were shown, were equally had side effects that were quite marked and quite severe. So, for example, zalcitabine was a drug that had a high level of peripheral neuropathy. It causes a toxic neuropathy in about 30% of patients. Stavudine did the same. DDI was very difficult to take. It was first of all available as a powder, then became quite a chalky big tablet before it became a capsule. So they were drugs that were developed in response to a crisis in terms of trying to find something that would work. But they were drugs that were really quite had high level of side effects.
Henry, can I ask you to turn to page 51 of the report? It's probably 52 of the document. And there's a table 4 there. Yes, so it's the page before that. Oh. So the inquiry has received a lot of evidence from people that took AZT in particular in the 80s. Can you, and you've created a table there that sets out some of the common side effects. Right. Blood disorders, anemia, neutropenia, nausea, vomiting, diarrhea, abdominal pain, headache, malaise, dizziness, myalgia, and lipoatrophy. Lipoatrophy, thank you. Yes, can anyone else add anything about, in particular in relation to AZT, but all of those first generation medications that you've just spoken to, about the burden of the side effects and the difficulties that Dr. Williams has raised about how difficult they were to actually take as a medication?
I just add something there, and I think that my very strong memory of AZT at the beginning, I think you're right, the dosing was very high. It caused anemia in a lot of people, and it got to the point actually where some people were blood transfusion dependent. So we used to have people who would take their AZT and then come in to have blood transfusions to deal with the anemia that was the side effect of the drug. So given there wasn't anything else on the market, we were managing side effects, really serious side effects, in order to try and continue to this drug. But we also had timers. I remember people used to get up in the middle of the night to take a dose, which was incredibly disruptive. So it was, as well as feeling terrible, it really had a lot of implications for life, for how you lived your life.
And a lot of those side effects, as we've heard, were very common and very severe, and some of those very long-lasting. So for those fortunate enough to survive, and still some of those patients in clinic now will still have some of those side effects as a result. So peripheral neuropathy, for example. And there's a condition listed here, which is a bit like cirrhosis, which we see in a small number of patients who had adenosine, that is still an issue today. So many of these things...
But can I just put the counter-argument that the trials of the use of zidovudine, AZT, to prevent or decrease the risk of transmission from mothers to their babies was extraordinarily successful. I mean, really groundbreaking work. And it is still used today. I mean, we still use zidovudine to protect newborn infants, to reduce the risk of transmission of HIV. So it's not, whilst you read these lists of toxicities, and indeed, in the beginning, I remember that very first child I looked after in 1988, we put onto continuous infusions zidovudine round the clock, 24 hours a day, because we knew so little about how the drug was distributed. But I wouldn't want to leave everybody with the impression that this is such a toxic drug that it has no place in modern medicine, because it is still being used today.
Well, the caveat to that, of course, is that we've learned. And so the doses that we are using are much lower. And we are able, I think, now to manage that drug in a useful way, whereas at the time that Ian's described, I think, we hadn't got that knowledge of how to best use the benefits it could bring. And so we saw quite a lot of toxicity.
Saying further that there may be people, and we still have patients who are still on it.
Absolutely.
And there is a minority of patients who don't get the side effects, and if they've been on the treatment for a very long time, it may still be an appropriate treatment to be on.
But I think it's important to know this was desperate times in terms of people trying to find something that would stop the progression to AIDS and for people dying. And so people would take medications in the hope that that would buy them some time, in the way that people might take cancer chemotherapy to buy them some time. So, undoubtedly, particularly, stavudine, DDI, and zalcitabine, all associated with quite severe major side effects. They're no longer particularly used these days. In fact, zalcitabine's been withdrawn, although zidovudine still has a role to play for some patients.
Yeah, and that's very short-term treatment for the infants,
And can I ask you in particular about lipoatrophy, subcutaneous fat loss, because that is a stigmatising side effect.
And that is still something that a lot of people who were treated with these first-generation therapies still have a problem with. And I still see lots of patients who have had developed lipoatrophy and who continue to need to have dermatological fillers to help alleviate that. The reason why lipoatrophy occurred is because, as I said, normally these drugs had an effect on the mitochondria of cells. The mitochondria are the energy parts of the cell, and they would affect how these cells functioned, and it caused in fat cells. It made them lose fat cells, and so they developed this lipoatrophy, which was, as you rightly say, quite stigmatizing in terms of appearances.
And again, we still have specialist services that are operating now, providing what we call new fill to try and fill in that lipoatrophy for patients. It's still a very common issue, and one that patients find very difficult, I think.
Is it worth just mentioning the actual what happens? This is a very what's the expression? Where sunken cheeks. And it's actually the other drugs with the buffalo hump, isn't it? So this was, So, and unfortunately what that looked like was like having AIDS. And so for lots of people that was very difficult, because they'd got through the point where they didn't look like the pictures of people with who had AIDS. And then when you go on these drugs, you did, despite the fact you were actually maybe being treated and potentially getting a little bit better. So that's the stigma.
And then came dual therapy. Again, can you give us an outline about how that came about?
Well, again, the virology of HIV developed along the same lines. We didn't know everything about the virus, but it became apparent that if a virus isolated from people who'd been on zidovudine for 6 months was more resistant to zidovudine than virus taken at baseline. So it became apparent that the virus was changing. It was mutating to become resistant. Okay? And we know now that's because, as I said earlier, the virus replicates at a high level. It does not proofread itself. It introduces errors. And so it can... And so any mutations that are introduced, which mean that it is less susceptible to that drug, will emerge. So dual therapy came along when we had access to didanosine and zalcitabine, and people then looked to see whether maybe taking 2 drugs as combination therapy, and there was large trials which showed that there was, again, impact in terms of 30 to 40% improvement in mortality associated with taking dual therapy. But people still, as I said in the report, people still continue to die. It wasn't, it was an improvement, but people still progressed and people still fail therapy. And we know now is because yes, it improved. It stopped. Then the viral load went down further, but it wasn't sufficient to stop the virus from mutating, developing resistance, and then for the viral load coming back up again, and then ongoing damage to the immune system to occurring, and people felt ill. So these effects were time limited in terms of. It's rather like you say, cancer chemotherapy might work, and then you have a relapse. It's the same sort of thing.
And in terms of the burden of the medication once patients are taking dual therapy, can you speak to that?
Well, Zidovudine, when it first used to be taken every 4 hours, and that was, as Jane said, that was the first sort of dosing schedule. But now for largely these were taken twice a day, right? But some of the earlier formulations I said before were very difficult. DDI in particular was a very difficult drug to take because of its formulation. It improved over time, but when the other drugs came along, then the pill burden increased. And this is on a background of people who also had to take drugs to prevent them from getting the opportunity infections that they had already experienced. So they were often on multiple, doses of different drugs that made it, impacted on their quality of life.
And because they're taking two
Yes.
toxic
Yes.
drugs now with side effects, does that double the chances of having side effects? Is that how?
Yeah, I mean, I think it's important to understand that these drugs were made available based on a randomised clinical trial that showed clinical outcome was better, right? So I think it's important to say that this what they had side effects that we were no longer, in today's regimens we would no longer tolerate, right? But at the time, large randomised controlled trials showed that taking two drugs was better than one in terms of improved mortality. And people wanted to, these things in medicine take one step at a time. And you need evidence from randomised controlled trials to be able to say, well, that is better than standard of care. This is how you then move on.
But in terms of the patient experience
Yes.
of taking those two drugs,
Yes.
was two worse than one commonly?
Yeah, they would clearly may have side effects from one and from the other. Absolutely right. So some, as Graham has indicated, would have no side effects, but side effects were very common. So diarrhea from DDI, nausea and vomiting from Zidovudine. So they definitely it impacted on them definitely.
And then we move on to triple therapy. Can you tell us about that?
Yeah, well, triple therapy came along when other classes of antiretroviral drugs became available. So nevirapine was the first non-nucleoside reverse transcriptase inhibitor, so it basically impacted on reverse transcriptase. And then the integrase inhibitors, not the integrase, the protease inhibitors, particularly indinavir and lepinavir, came along in 96, 97. And so these were drugs that acted in a different way to the NRTIs. And trials of 3 drugs versus 2 drugs, again, showed an incremental improvement in terms of clinical benefit. And so trials of indinavir plus 2 nucleoside analogues was shown to be better than just 2 nucleoside analogues on their own. And at that point in time also, trials had an endpoint of a clinical endpoint, right? They were looking at determining on mortality rates and on progression to AIDS. But then as the virology improved and we were able to measure the virus directly with new technologies, looking at virus detection assays, we could then monitor the effect of these drugs and the amount of virus in blood. And it became, from those large clinical endpoint studies, it became apparent that if you were able to press the virus and keep it down and keep it suppressed, then that resulted in an improvement in the immune system. And so the changes in these surrogate markers, in the CD4 count in the viral load, captured the clinical benefit. So it's rather like, for example, if you were treating high blood pressure, the outcome of a high blood pressure is stroke. But to do a clinical trial, you do a clinical trial to look at its effect on blood pressure. And so it wasn't until 1998, until the 1990s, that we moved from doing large clinical endpoint studies to doing trials which looked at viral load as an endpoint. And at that point in time, with triple combination therapy, I remember going to Vancouver conference in 1996, and it was a fantastic experience and to be able to see these improvements with the triple combination therapy. It made a huge impact in being able to suppress the virus, and the virus did not emerge with resistance. It maintained viral suppression.
And in terms, again, of the patient experience of taking these medications, if we go back to the table that we were just looking at, there are an enormous amount of medications on this table, and I don't want to go through all of them, but could you just pick out for us where some particular medications, or where a medication came on the market that seemed to be better tolerated by patients than the previous ones?
Well, I suppose that didn't really come until the mid-2000s, right? I mean, indinavir was a protease inhibitor, but it was very difficult to take. You had to take it 3 times a day. You had to have a high fluid intake. There was dietary restrictions, and the high incidence of renal stones with it. Ritonavir was originally a drug that was used for treatment of HIV infection, but it was a really difficult drug to take in terms of it's now only used as a booster for that. Nevirapine was associated with quite severe rashes, and people sometimes were admitted to hospital because of a severe rash associated with nevirapine, although it's still a drug that we use quite a lot in people who can tolerate it. And as we move sort of through, so between sort of 98 through to the mid-2000s, other newer drugs emerged, and newer nucleoside analogues emerged in terms of lamivudine and in terms of tenofovir, which didn't have the sort of side effect profile of the D drugs that I mentioned before, and newer protease inhibitors became available, such as darunavir and atazanavir, which were better tolerated. Protease inhibitors generally, particularly drugs like Kaletra contain lopinavir and ritonavir, had really, people dealt with huge problems with gastrointestinal side effects like diarrhea. It was a chronic problem. And drugs like sequinavir, also high dose burden, but also lots of problems with diarrhea. Now, alfinavir, another one. These are early generation protease inhibitors. They advanced our knowledge. They helped us move forward, but they were by far ideal, right, in terms of their pill burden and in terms of their side effect profile. So it helped people, but they had to deal with a lot of people had to deal with side effects. It wasn't really until I would say the mid-2000s and a bit later, when the integrase inhibitors became available, that we truly got drugs that were much better tolerated.
And I think just to add to what Ian said, particularly about the early protease inhibitors, is that it was very hard to get a high enough level in the blood to get a therapeutic level. So you either had to take a lot of pills a lot of times a day, or you had to take something that would help you boost it, which was where ritonavir came in. But I have a very strong memory of the early days of sequinavir, when grapefruit juice was found to be something that could boost. So people would have... I can't remember, handfuls of pills 3 times a day and be advised to have grapefruit juice, all in order to just to get the drug level into the therapeutic range. So there was quite a lot of, and even if it wasn't necessarily causing a side effect, it was certainly causing a lifestyle effect, and then the gastrointestinal symptoms that you were talking about as well. So there were difficulties in actually managing. In the early days of DDI, you described those chalky pills, and before that it came as a sort of sachet of powder, and you dispensed a sort of great shoebox of stuff, and then they tried to make it flavour. Do you remember there was cherry flavour that you could add, and they were revolting. But again, as Ian has explained, they were making some sort of difference, and so people put up with, and we put up with, prescribing things that were really difficult to take, not just making you feel unwell as well.
I mean, I still have patients who I look after who accessed triple therapy for the first time in 1997. It saved their lives. There's no doubt about that.
Absolutely.
I must be very clear about that. The advent of these of triple therapy, highly active antiretroviral therapy, despite the problems of pill burden and side effects, made a huge difference to some people.
Yeah, absolutely echo that. And I think we learned, we were seeing after that, the Vancouver conference
Yes.
and the introduction of protease inhibitors, a really dramatic shift. And actually, the cost in lifestyle and all these other things, there was a benefit, a really clear benefit.
I'd just like to say one thing. If you could scroll right back up to the top, there's a little line there that says, for the interests of space, we haven't included enfervatide. But actually, it's worth remembering that back in the 90s, there was that interlude
Yes, there
when we really had run out of new agents, and T20 or enfervatide, which is right at the very top of the table and not in the table.
I didn't put it
There, that line there, enfervatide. I mean, my memory was that this was a twice daily injection
Yes, it
that was subcutaneous and very difficult to reconstitute, and actually caused a lot of injection site reactions. But we were using it, and our patients were. I mean, again, it bought time. It actually did tide people over long enough to survive to take advantage of triple combination therapy. But it was a really difficult drug to tolerate.
Can I just make a couple of things, and maybe again Gareth will pick up on this. But this was it was a bit of a different game when you were talking about children, and many of these drugs were not available for children, although some were, and you can expand on this. But I think from a nursing point of view, how do you get these young children to take these drugs? And we've already described how hideous they were to take as an adult when you can rationalise what you're doing, but to try and give a child something so revolting was very, very challenging. I think the second thing to say is the confidentiality issue that is associated with drugs. Because people had fridges full of drugs, they had bags full of drugs. I still know people today who make sure they take their drugs before they go to work, and they're on 1 or 2 tablets a day. People were taking about 28 drugs. It was an enormous amount of drugs, including some of the prophylaxis for opportunistic infections, which reduced. But maybe you want to expand on the children, because it was a different scenario for the families who had small children.
Yeah, okay. I don't want to spend too long, but it was a challenge. The pharmaceutical industry, in fairness, was trying to work very hard with us to produce formulations that children could take, but they were often. Ritonavir as a suspension is utterly repulsive, and I wouldn't allow any doctor in our team, any new doctor joining, junior doctor, to prescribe ritonavir if they hadn't tasted it first, so that they knew what they were actually what we were asking parents to do with their children. And we ended up quite often inserting gastrostomy tubes, because a tube that will sit in the stomach wall through which you can give the medicines, simply because you can then avoid all of the taste bud pathways that were so difficult for parents to manage. It was a challenge.
And I think you say in the report, Professor Tudor-Williams, that the drugs that did come on for children, the trials that did take place for children, were far later than for adults.
They tended to lag behind. We tended to have less choices, and therefore children were kept on their first-line therapy for longer, and these were not easy therapies, so we ended up with, in those early days, unfortunately, selecting out highly resistant virus in a population of the early treated young people.
Just add one quick thing, which is, of course, some of these side effects also had issues around bleeding. And so if you had haemophilia, that you weren't able to take some of these drugs because of the problems with bleeding. I think we've written that somewhere.
Can you then take us up to the present day in terms of the history of the medication?
Yeah, so triple therapy definitely made a huge impact, and certainly from 97 to 98, the incidence of new opportunistic infection, incidence of AIDS, started to fall. We saw a dramatic impact on both that and mortality, but the drugs were not ideal. And so during the late the sort of 2000s, the integrase inhibitors became available. Eltegravir in 2007, and then the other integrase inhibitors later on. and safer drugs in terms of nucleoside analogues like tenofovir also became available. And the pill burden started to fall, and people started to be able to take regimens that were once a day and now regimens that are in a single pill. And they became more tolerable, right? A pivotal study was a SMART study done in the mid-2000s, which looked, because to sort of consider what the thinking of was at that time, there was a sense that some of these drugs had sufficient high adverse events that maybe taking them periodically will be better than taking them all the time. And therefore, there was a trial that was done that randomized people to take medications periodically depending on their level of CD4 count in their blood versus taking therapy all the time. But that was the result of that trial was pivotal because it showed that the control of virus all the time was far better. It had a far better improvement in clinical outcome. And so that changed the way we looked at things. And then as medications become more tolerable, not to say they didn't have side effects, but they became more tolerable in terms of people being able to take them more, better, then it became clear that we needed to start therapy in everybody. And it wasn't until 2015 where the outcome of a trial looking at early versus deferred antiretroviral therapy, where we showed that actually even if you take therapy as soon as you're diagnosed with a high CD4 count, you have clinical benefit in terms of risk of progression to severe disease. It went down, it sort of halved, but it was only in terms of 4% down to 1.6%, but it told us that treatment at any level of CD4 count was important. And from 2015, guidelines changed, which then indicated that that people should be offered therapy at the point of diagnosis, and Public Health England now monitor the outcome of therapy, and we know that from recent data that of those patients who are diagnosed and attending clinical care, 97% of them on therapy, and of those who are on therapy, 97% have undetectable viral loads in terms of their viral suppression. Having said all that, that is a biological outcome in terms of viral suppression, and that doesn't, one needs then to acknowledge what are the quality of life issues around taking therapy all the time, and the other things that we talked about, comorbidities and everything else, and mental health disease.
So just sticking then on the burden and the side effects of the modern treatment.
Yes.
Where are we in relation to that? How is that experienced?
Well, certainly someone starting antiretroviral therapy today will have a much different experience than someone starting therapy 20 years ago. There's no doubt about that. In that most people starting therapy for the first time today will take a regimen that may only contain 1 or 2 pills, and there'll be drugs that are better tolerated. Their discontinuation rate due to side effects will be only a few % at 1 year, and they will tend to continue to live normal lives and go to work. And yes, people experience side effects, as people experience side effects from any medication prescribed for any condition, but generally it is much better, right? Having said that, those people who've been treated before, they will often be on much more complex regimens because of issue around resistance. They may have developed resistance to the previous drugs, and therefore their regimens may be more complex. There may be twice a day, maybe more medications within them, and they may therefore have more side effects associated with that. So there's a very difference from someone starting therapy for the first time, diagnosed today, compared to someone who's been on therapy for 20 years, where they have the burden of problems from over 20 years, and what may be needed from therapy in them compared to someone who's naive to therapy.
And you have said that the 97% of
Yes.
those who take antiretroviral therapy have reduced their viral load to undetectable amounts. Can you explain what that actually means?
Well, again, I don't. That's a very biological outcome to a certain extent, and I don't, because I think it's important not to. One needs to emphasise the other impacts of taking therapy for a long time are, and we've sort of alluded to that earlier, right? But what that means is that if you suppress the virus is therefore unable to change and mutate, right? And therefore you don't develop resistance. Resistance does not develop, and therefore there's absolutely no reason that as long as you continue to suppress the virus through antiretroviral therapy, that people will not fail therapy. And the main reason why that will occur as long as people are able to adhere to therapy. So one of the things that is very important about treatment is that people need to adhere to therapy at a high level, so more than 90% of medications. So that in itself is also something important to emphasise and to do. But what the viral suppression allows the immune system to improve, right? I alluded to earlier, rather like being on a treadmill. If you can come off the treadmill, you recover. And that's exactly what happens. It allows the immune system to recover, it allows it to rebuild itself, and it allows the immune system to do what it should do, which is prevent other infections occurring. Clearly, starting therapy at a higher level, at a higher CD4 count, is better than starting therapy at a lower CD4 count, because you're having to rebuild the immune system from a very low level. Not that it can't be done, but it's associated with more morbidity.
And for once a viral load is undetectable, is it right that it's been known for some time that means that it's not untransmittable?
Yes, I mean, the viral being undetectable is basically based on an assay that we use to monitor viral load in blood. It's not to say the virus has gone away. The virus is still there in cells that are quiescent and latent. And if you were to stop therapy, the viral load comes back up again.
So it's not been cured. There's been no cure.
Not been cured. It's about maintaining viral suppression through drugs that inhibit viral replication. It's not about cure or eradication, right? That is very much the goal that scientists are trying to look at. But at the moment in time, therapy is lifelong, and people have to take lifelong therapy every day. So that's, again, that has an impact in terms of how people see themselves as a chronic condition.
I think it's also important to just reinforce Ian's point about undetectable. So the terminology has come from the laboratory assays, and the level that we call undetectable has changed as the assays have got more sophisticated. So it is about looking in the blood to see how much viral replication is going on. And the early tests, you could find 400 copies per mil, and that would be the level of detection. And then it went down to 100, the more sensitive assay. Then it went down to 50. Then it went down to 20. So it's referring to what the laboratory test can do and the sensitivity of it. So it is undetectable on the test. And again, it's really important. It's not gone away. It's just that the test has got the limit of its sensitivity. But
it's also, you alluded to the question about being untransmittable. Certainly, if you reduce the virus in blood, you reduce it in genital fluids, and therefore we now know from randomized controlled trials that if you go onto therapy, it reduces the risk of transmission to an uninfected partner by 95-96%.
Through having sexual relations.
That's right.
Well, and from vertical transmission, because the greatest risk factor for vertical transmission is a high viral load in the mother. And a woman who has an undetectable viral load, the risk of transmission is, well, Gareth?
Well, less than 1 in 1,000.
Yeah. And how about transmission via blood?
Well,
there's not a viral load.
Sorry?
Yeah, wherever.
Yes.
It's all about viral load.
I would have to say there isn't the same level of evidence, right, in terms of example in injection drug users, and clearly in products and blood products are now screened for that. So there isn't that evidence. So the evidence comes from sexual transmission, because that's where ongoing transmission occurred.
So it's difficult to really underestimate the transformative impact that triple therapy had in not just for individuals, but for the management of the whole disease. So it transformed what was essentially a disease of progressed immunosuppression, which was managed in hospitals. In my own setting, where I imagine Jane was at the time, there may have been 40 or 50 patients in that hospital, and we now have maybe 3 or 4. And what's happened is we've moved HIV to a much more of a chronic disease, like we might manage diabetes or hypertension, which is in outpatient clinics, and we now have maybe 100,000 patients in the country on this treatment. And it was really that in the middle of the 1990s that transformative change came about.
Absolutely. I think the other thing which Sian has alluded to is the need to continue therapy. Something I hear from patients is the reminder that every time you take a pill, you're still living with HIV. And sometimes that can be a barrier to adherence because it's a constant reminder. And there are some drugs at the moment only in clinical trials which are looking at either longer-term injectables or depots, which may again change the field. But for the moment, somebody will need to take tablets every day at the same time.
You've told us that the antiretroviral therapy is not, for 97% of those that take it, is highly effective. Is it more effective for somebody that's newly infected and goes on to those therapies, those modern therapies, rather than someone that's had HIV and been living with it for a long time?
The thing that determines response is the ability to take the medication. Depends on your previous exposure and development of resistance, and on other comorbidities that might impact on the side effects. So yes, someone who's diagnosed now at an earlier age is likely to have a much better experience than someone diagnosed, well, they will have a much better experience than someone diagnosed 20 years ago.
And we haven't really touched on life expectancy.
Yes,
So we would expect that if someone was diagnosed now in a timely way, was able to take treatment and take that treatment every day, that their life expectancy would, as far as we can tell, be the same as if they didn't have HIV at this point. And that was obviously not the case for a very long period of time. And
just picking up on that point and developing it further, for someone that's been living with HIV for a long time but is on these modern drugs now and has undetectable viral load, what's their life expectancy?
Can I just I'll answer that question if I could quickly come back to the fact that in terms, I don't want to get the inquiry to understand that although these modern drugs are much better tolerated, they are not without their issues for individual patients. So sleeping difficulties can still occur, anxiety in some patients, gastrointestinal symptoms, loss of bone density. So there are things that need to be monitored for, even with these modern drugs, but they are, compared to the older drugs, are much better. So I would not want the inquiry to think that they are absolutely perfect, because they're not. They're much better than they used to be, and people tolerate them much better, but there are ongoing issues where we would like to improve on them.
And one of the more common things we still deal with is neuropsychiatric side effects, even from the drugs today. Often relatively mild and not as common as they used to be, but nonetheless there. And even with the new options we have, we still sometimes have to rely on drugs which cause that, and that obviously adds to issues that might exist before those drugs are started.
Can I add one thing onto this as well, and that's, I don't think we can underestimate adherence as an important component to this drug therapy. And when you start newly on a drug and the doctor says to you, you need to take this drug every day at the same time for the rest of your life, somewhat easier than you've been spending 20 years or plus taking all sorts of drugs that may not have worked. You're very sick, you've been very sick. And we were talking earlier on about psychological impact, and that we know that the psychological impact of depression and anxiety has a very negative effect on adherence. And the second thing is about relationship with the healthcare service. And I think that your relationship with your doctor, your relationship with your nurse has a very strong correlation with how able you are, whether that mentally or physically, to take these drugs and keep taking them at the same time every single day. And so I think that history that you're talking about of people being unwell for a long time has a big impact on that aspect.
And I think there's another aspect of that which I think you might come to, but the increasing understanding of the importance of peer support in things like adherence. And so within clinical settings, making sure that there are people with the experience of living with HIV and taking medication who can support people on that part of their treatment, because actually sometimes having experiential expertise is incredibly helpful in helping with that.
I did ask a question about life expectancy,
Yes.
but I can come back to that.
Sorry.
Can I, but just on that point, because you asked the question about if you'd been living with this for 20 years, how could you, what's it like taking today's drugs? And from my experience, every time we look at, and we are constantly trying to find the best possible tolerated options for the young people as they're growing up and as we have more things to offer. But every time we look at that decision making, we go back and look at the archived resistance. I mean, Ian mentioned this, that the virus is very capable of lying dormant, latent inside cells for a very long time. And the worry is that when you've been exposed to monotherapy or dual therapy and you've archived those viruses with that resistance, we take that into account when we think about the options today. I'm sure it's true in adult practice, isn't it?
Yep.
What are the long-term effects of taking antiretroviral therapy then? Even the well-tolerated drugs for people that are going to be taking it for a long time for the rest of their lives?
I think the answer to that is we don't know.
Wait to see.
To be honest, I mean, clearly we have experience from some of the older drugs, and that we've mentioned peripheral neuropathy can be, the symptoms of peripheral neuropathy can be long-standing and be a problem for many, many years, even after you've discontinued the drug that was causing the problem. Many of the early drugs like didanosine or stavudine have had long-term impacts on liver and pancreas, and people developing liver disease and pancreatic disease 10, 15 years later. So there are those. So if you ask me, what are the long-term impacts of the current modern drugs? We haven't as yet seen any signals to be concerned, but like any long-term medication, we need to continue to be robust in being able to identify that. There are, for example, tenofovir. There are two forms of tenofovir. One is tenofovir DF, one is tenofovir AF. Tenofovir DF was the first version. That can be associated with chronic kidney disease, but it can be also associated with bone loss. But that's largely been replaced by a newer version of tenofovir. So again, experience will tell us that there will be something down the line that may well, which has not been identified in clinical trials. Often you identify in clinical trials what are the most common side effects, but when you put the drug into a larger patient population, in a clinic population, then you experience problems associated with that drug in a more diverse patient population.
And it's probably fair to say that we see these cycles of excitement and then tempering of that excitement over the years, where we're dealing with patients with drugs where we know that they're not perfect. Something new comes along, new and shiny, and everyone's excited about it, and we tend to use more of it. And then gradually, often, we've found that there are side effects and have had to rein back. And still, there will be some patients who benefit, but we learn a bit more about it. And even with the newest drugs, we're still going through that cycle,
Yes.
I think.
But there's also an issue, I think Ian's alluded to it, the diversity. So as people who are living with HIV get older, not only are they taking drugs for a long time, but they are physiologically changing. The human being is changing as well. And so we don't necessarily know about how that's going to play out. And there's far less data at the moment on women. They tend to be less well represented in clinical trials, and older people are underrepresented in clinical trials as well. So those are areas which we still have to find out about.
That was a question, in fact, that somebody specifically asked me to ask the panel, which is what impact is the ageing process going to have on the effectiveness of these medications?
I don't think it's an impact on the effectiveness, because I think as long as people take the medication, then the viral replication cycle will be prevented. But clearly, as people get older, the dose of the drugs might need to be adjusted. We know little about that, because the way the drugs are handled by an individual as they get older. But I think there is an important issue about whether HIV has an impact on aging in terms of the interface with someone getting older and the interface of disease associated with aging and HIV, and whether there is HIV is associated with either accelerated aging or attenuated aging. It's generally thought to be associated with attenuation, that diseases of aging tend to be much more common in people with HIV rather than premature.
Is there anything anyone else wanted to say about medication before I pick up on the life expectancy question? So we started to digress into life expectancy, and I think what you said was for somebody who's newly infected and goes on to these modern drugs, life expectancy is pretty much as it is for somebody that doesn't have HIV. The next obvious question is, well, what's the impact of life expectancy compared to somebody that doesn't have HIV?
May I just ask a question about that? It really arises out of what you were saying about the long-term effects of having drugs. It must be the case that no one in the UK has suffered from AIDS for longer than 40 years. So, so far as those with haemophilia are concerned, the cohort may be largely younger than older. How do we know what the life expectancy is going to be?
The answer, Brian, I think that's a very important point. And I think we do so. All we can do is estimate through epidemiological models. And so people more, with experience in the epidemiology and life expectancy, the ones who've looked at this, right? But what they do is they look at the incidence of different diseases associated, in someone who's age 60 or 70, and they extrapolate from there in terms of what the deemed life expectancy is. But no, you're absolutely right. I don't know what's around the corner in terms of this. There could be something that could develop that would be, that is unexpected. But experience to date suggests that once you, when people have been on therapy for a long time and they have recovered their immune system, then generally they live their incidence certainly of diseases associated with severe immunosuppression is no longer there. But what there is a concern about is, which I alluded to earlier in the previous session, was the fact there are issues around diseases of aging and cancers. That's what I am seeing now in my cohort, is that,
and presumably the effects of mental
yes, absolutely.
problems.
Yes. Absolutely right. So, living longer is fine, but living well and longer is really important, and that's where we, at the moment in time, can't guarantee that.
Turning then to those that have been living with HIV for many years, what do we know about life expectancy for those patients?
I think it's a question that I can't answer to a certain extent, because I don't think we have, as I said before, there are epidemiological models which can model this, but most people, the way they publish this data is looking at someone diagnosed now, right? And someone living, who's been living with HIV for 20, 25 years has had a damaged immune system for a much longer time than someone who's diagnosed now. And having a damaged immune system for a long period of time has its long-term sequelae, particularly in terms of cancers. And as I said, frailty is a problem in people getting older with HIV, because it's not just about living longer. It's about the quality of life, and frailty in someone with HIV living longer is much higher. So they tend to have much more conditions of aging. The prevalence of those conditions is higher, right? And therefore, diabetes, blood pressure problems, cardiovascular disease, renal disease, it tends to be they tend to have more complex problems. So, yes, life expectancy has improved a great deal, but where we are now is trying to improve and reduce these other conditions that impact on frailty and quality of life.
Professor Tudor-Williams, can I ask you, from your perspective, the same question? In your report, you suggest that outcomes are better for those that were infected between the ages of 5 to 15 in terms of, as I understand it, in terms of life expectancy. Is there any other information that you are able to share with us about
Well,
that?
I mean, there are limited data specifically from haemophiliac cohorts looking at that kind of actuarial survival that would suggest that those that were infected at a younger age have done better than those infected who are older. And I think that just simply reflects that the older ones already had comorbidities that were prejudicial, that gave a survival advantage if you were infected younger. But I think that I tried to put a little bit of data into the report relating to our cohort of young people who've been living with the virus that was perinatally acquired. So, they reached their 20s having already lived with the virus for 20 years. And it's clear that there are increased morbidities and mortality rate that is related to both an increased risk of cancer, some increased risk of mental health issues. Our own cohort data shows that there's probably a 13% higher incidence in our young people up to the age of 24 compared to the non-HIV infected same population, and also a 20% likelihood of mental health issues with 3 of our cohort who've attempted suicide. And I think, therefore, it's incredibly difficult, as I said, that the long-term outcomes for the young people who are infected surviving into adulthood are really difficult to model at the moment. And I think we would be unwise to be drawn into guesswork about what the future holds, because whilst there may be some unexpected and adverse problems lying ahead, equally there may be some amazing breakthroughs that everybody's going to be able to take advantage of. And I remain an eternal optimist from that point of view, and I really hope that that anything we say today will be trumped by advances in therapy tomorrow.
Can I say that I don't think we can underestimate the mental health issues, and we're talking about mental health issues about certainly with people who had haemophilia who were diagnosed very young, and all that. The whole issue of the problems with schooling, the problems with lack of interest or ability to have a future that they could hold on to. They've been told that they were going to die. They've watched their friends die. They've watched their brothers die. We've discussed all this on Tuesday, but I think that it's a profound effect on the mental health. So if you've been living not only with these physical illnesses that we've been talking about, these long-term treatments we've been talking about, but also a sort of a loss and grief in your life, that there's a lot to deal with that interrelate with one another.
So I note the time. If this is a convenient time to break, we will be collecting questions from any call participants to be put to the expert panel in the last session.
Thank you for that. I think it probably is convenient. Let's be back here then at 3:30.
Thank you.
3:30. Well, now, before we turn to the next topic, can I just check something with you and see that I understand it correctly? And you can tell me where I've gone wrong. Can we have a look, please, Henry, at what the picture on page 3? Well, it's a couple of pages further on. That's it. That's the one. This is described as HIV treatment explained. Now, so, to understand what the explanation actually is, can I just see that my understanding's right? The little dot at the top, the HIV, labelled HIV. That's where one starts with. That's a viral particle.
Yes.
The big circle in the middle is the cell with the nucleus in the centre. And the net result of the viral particle entering the cell is to render the cell ineffective at doing its job in the immune system. And you end up with, well, here it shows 5 little particles coming out at the far end. I suspect that's representational, but it means that one viral particle comes in, a number of more come out. It clones itself.
Yes.
You're nodding. That's for the transcript.
Yes.
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 I mean, it's rather, if I can say that the nucleus is rather like a computer. And so what the virus is doing is basically encoding itself into the computer.
Well, can we just take it stage by stage?
Yes. Sorry.
First of all, it's got this viral particle has got to get into the cell through the cell wall. And you mentioned earlier, though I don't think it's shown directly on this, the importance of the CCR5 co-receptor, which some cells don't have, a number most do, and it's by binding to those, is it, that the particle can get into the centre of the cell?
Yes, there's 3 stages to HIV entry. There's the virus will bind directly to the CD4 molecule through its GP120, and then it will then bind to the co-receptor, which is either CCR5, but there are others, and then then there's a 3rd stage, which is fusion with the cell membrane, which then allows the virus to inject the viral RNA into the cell cytoplasm.
So here we are with the orange arrow showing the little particle coming through the cell wall, and then at stage 3, we have the HIV RNA. Now, you've described how HIV consists of a strand of RNA, whereas what is in a cell and gives you the cellular message is DNA.
That's right.
Reverse transcription is creating DNA out of RNA,
That's right.
it?
Yes.
Rather than the other way around, which is transcription, hence
Yes.
reverse transcription.
Exactly.
Yes, exactly.
So there we see the 2 separate strands of RNA combining to form a dual strand.
It's a single strand of RNA.
Single strand,
Strand,
right?
which will
So
become a
there's 2
double-stranded.
single strands, but it curls itself round to the double helix.
Absolutely, into a double-stranded DNA.
And so you've got a bit of DNA, but it's not a complete bit of DNA, not a complete...
It's the viral. It's encoded. It's all the viral genes, right? But it's in a DNA rather than an RNA copy, and so it allows the DNA then to be encoded into the cell nucleus.
And if it's encoded in that way, then it can replicate.
Because when the cell is then activated, the cell reads the DNA in its nucleus and will then produce new products as a result of reading its cell DNA.
And,
So,
it's that integration that makes cure so difficult, that is different from other viruses, so that DNA is then integrated into the human DNA.
Right. So the first stage is entry, the second stage is reverse transcription, and then once this bit of DNA has been produced, it has to be integrated into the centre of the cell. That's the integration, that's stage 4, I think is shown here.
That's right.
And then, having got in, the new viral material is produced, and that's what you say. You say, or the diagram says here, it's cut and assembled by protease, which is another protein, is it?
Yes, it's
Enzyme.
the virus encodes for 3 enzymes. It has 3 enzyme products, which is reverse transcriptase, integrase, and protease, and it needs all those 3 enzymes to be able to produce a new virus particle.
And each of them at a different stage. So
That's
there's the entry, first of all. There's reverse transcriptase, the enzyme which allows for reverse transcription. Then you have integrase, which allows it to integrate into the centre of the cell. Having got into the centre of the cell, it starts to reproduce, and that's when you need protease, which
It will reproduce only if the cell is activated. So if the cell is not activated, the viral DNA, proviral DNA, will remain in the cell nucleus, and the cell will become a resting T cell, which might live for many tens of years, and that is the reservoir of HIV infection that is so difficult to eliminate.
So the way in which, or the bits which the treatments you've told us about target are, first of all, you've told us about nucleoside and non-nucleoside reverse transcriptase inhibitors. And what the way that the way the nucleoside work is that by competing with the.
So it competes when you build a DNA, you need to build it with building blocks, nucleic acids. Okay, so the things like zidovudine are analogues of nucleic acids, right? And so they compete with the active site of the enzyme to get to be put into the expanding DNA chain. So that is that's the sort of competitive sort of inhibition.
So to use a homely analogy, it's a bit like elbowing the viral aside, trying to get into the queue.
Yeah.
Like a tube train, some people may get on and some people may not.
Yes.
So then the integration, that's the integrase inhibitor. And I haven't asked you about the non-nucleoside. Does that deal with the process of transcripting
what the
directly?
non-nucleoside does is that it binds something just slightly separate, just slightly distant to the active site of the enzyme, but in doing so, it distorts the active site, and therefore the substrate, which is the nucleic acid, can no longer be bound to it, and therefore it stops the work of the enzyme.
Yeah, it sort of buckles the door of the tube.
That's right, yes. Yeah.
Thank you.
It's like a zip, in fact, the teeth of a zip, and you can, if one of the teeth of the zip don't work, then it won't go down. And the non-nucleosides, this is how I explain it to nurses anyway, and the non-nucleosides is like putting a bit of cotton or fluff in the actual zip at the top, so you're not going to go anywhere at all. So all those little teeth of the zip are like the nucleosides going down the zip.
And with the working of integrase, do you have an explanation for that?
Well, integrase will allow the DNA in the nucleus to be spliced and allow for the proviral DNA to be inserted. So what it does, it stops that from happening, and therefore the proviral DNA just loops itself around and is not encoded.
So it's sort of cut and paste.
Yes.
That's right. Yeah. Yes.
And then the protease
Not pasted.
Not pasted. Just cut.
Just cut, but not pasted.
No cutting, right? Just pasting.
No
Yes.
pasting.
No pasting.
No pasting.
No.
Right. Sorry. And then the protease, that's taking apart proteins and reassembling them in
Packaging.
the
Yeah.
viral.
So larger when the cell is activated, it will produce new viral RNA, and it produces new messenger RNA. And the messenger RNA is responsible for producing large polyproteins, and those polyproteins need to be spliced in order to have a mature virus particle.
Now, when we're talking about triple therapy, it might be thought that what the aim of the therapy would be to have something which stopped reverse transcription, something which stopped integration, and something which hindered reassembly by protease. Is it like that, or do we actually have two different drugs which have a go at reverse transcription?
All you really need to be able to do is to stop the virus from mutating, right? So it stops that you can stop the virus from replicating, right? But what you don't want to do is allow the virus to slip out and transform itself to something that will still replicate in the presence of drug. It's rather like if you treat TB, if you give it one drug, it will get resistance very quickly. You need combination therapy to treat TB. So it's the same sort of thing. Because the drugs are acting at different sites, and there's 3 of them involved, then it's much more complex and much more difficult for the virus to escape that sort of hold.
So essentially, that's how triple therapy works, is it?
But by and large,
However-
to answer your question there, then it's unusual to have one of each together.
Exactly.
So
Yes.
it does tend, partly for historical reasons, to be 2 drugs targeting the reverse transcriptase
Yeah.
combined with one other,
Exactly.
at least
So
when you start.
the triple means 3 different molecular drugs, not 3 different sites of action.
But and one site of action will almost always be reverse transcriptase,
At the moment, yes.
At the moment.
and it may be one of the other sites.
Yes.
And did I understand from your report that we have 4 stages? Entry is the first stage, which is not necessarily the same sort of enzyme process as the other 3. But there are now drugs which are being developed or have been developed to stop entry as well.
Yes.
Yes.
Right.
Yeah, T20
T20.
was an example of that totally new class of drugs, which is why it was effective in the face of a lot of resistance to reverse transcription, for instance. So once you got reverse transcriptase that was no longer inhibited by the existing drugs, T20 blocked that whole fusion process. And there are now new molecules in that class being developed.
But there's no point in doing all 4 together, all 4 stages?
You're getting down to
It
2.
depends.
Right.
Generally, where there have been trials done of comparing 4 versus 3, generally there hasn't been an advantage to doing that.
And in fact, latest trials are actually going down to 2
2.
drugs now.
Ah, right.
And some of the other entry inhibitors block some of the co-receptors as well. So there are molecules that can block other bits of entry.
What's important is the drug has a high genetic barrier to resistance. So if the virus needs to do a lot more work to get resistance to that drug, then that drug is generally more successful. While if it only needs one nucleic acid chain to get resistance, then that means that's a low genetic barrier drug.
Well, thank you very much indeed. I don't know if there are any questions which arise out of that for you, Ms. Scott.
I don't think
That's all I'm going to ask.
in your report, you've got a section on the impact of HIV on those with blood and bleeding disorders. Professor Rockstra is coming to give evidence tomorrow, and you've told me that he is the best person to direct those questions to. Is that right?
Yes.
Correct, yes.
So then, can I move on then to the parts of your report that deal with the information that should be given to patients? I'm going to ask you a couple of questions about diagnosis, and then pick the report up at page 61 about what should be given to patients on diagnosis. The inquiry has heard lots of evidence from different people infected by HIV that they were not told of their diagnoses at the time that the test that it was discovered that they were HIV positive. Can I ask you whether or not it's ever been acceptable to withhold an HIV diagnosis from an adult patient with capacity?
No.
No.
Has it ever been acceptable to withhold the diagnosis of HIV of a child from a parent with capacity?
No.
And just sticking with then the diagnosis, Professor Tudor-Williams, you in your report, in the section of the report I believe you authored of about children and adolescents, make some comments about how practice has changed in terms of informing young people of their diagnosis of HIV themselves. Can you just tell us about that?
So back in the early days when we didn't have very great treatments to offer, there was a huge worry, and obviously much of my experience was with young people who were infected as a result of vertical transmission rather than through blood products. Of the children in this country who were infected through blood products, it was about 10% of the overall 2,500 or so children who have lived with HIV. And so there were many reasons. We were very often, it was a family condition, we were very often dealing with parents who themselves were infected, who were dealing with their own feelings about that diagnosis, and who found it extraordinarily difficult to allow us to tell the young people growing up with HIV that that was their diagnosis. And the result was that we very often, not through our own desire, but out of respect with dealing with the family's wishes, delayed telling the young people. And they'd say, well, no, they're just about to go to secondary school. That's not a good time for them to know. And no, they're just, they're not really into puberty yet, so let's do it when they've gone through puberty. All sorts of reasoning would postpone us from letting the young person themselves know the name of the virus. And I think part of that was because of the whole Tombstone campaign and the huge stigma that was associated with it. And they didn't want their children to be burdened with this knowledge. But what we learned over the years was that, in fact, if you discover that you are living with a sexually transmissible virus at the time that you go through puberty and at the time that you start negotiating intimate relationships, that is a disaster. That is really difficult for young people to cope with. And it is much, much better if they assimilate that knowledge long before they're into any kind of those personal relationship issues. And over the years, we've really come to the point where we are much more I think paternalistic in a way with the parents, and say, actually, we really, in this instance, we really do know best. Please trust us. It's going to be a great deal better if you're young, if the youngster, is your responsibility. Your child knows about this at 10 or 11 years of age with the name of the virus when it's not really a big deal. HIV, human immunodeficiency virus, it's just a name, and it doesn't carry an enormous amount of weight. And then all of the education that goes on from that time forwards prepares them to understand both themselves, where they stand in relation to other people, and we help. I mean, what has made an enormous difference is this equation, U equals U. Undetectable equals untransmissible, so that they grow up. And we're already in that position to be able to say, look, here on the computer is your viral load. It's undetectable. That's great. It means that you will not pass this on to anybody else, provided you can keep taking the medicine. So it sets them up for a much, much better psychological experience going through adolescence.
And so you were talking about the name HIV not having any meaning to them because they're so young and they don't know about the stigma of the disease. Is that what you're describing?
Well, it gets over that hurdle of, oh no, we mustn't tell them the name of the virus. And actually, for younger kids, it's not a big deal. It's just the name of a virus, and they don't go home and have sleepless nights about it. If you're 10 or 11, if you're 15 and you hear about it for the first time, that is really hard.
Yeah, so that they learn about the virus and how to manage it before they understand the stigma and the psychosocial impacts and so on of it.
Yeah.
Can I then, you deal with these issues in great detail in your report about the advice and the information that should be given to patients on first diagnosis, what should happen to them once they've been diagnosed in terms of signposting them on to secondary care, etc., referring them on to secondary care. And you deal with that in great detail, and it's, for those that have the report in front of them, it starts at page 61. So we can probably deal with this fairly quickly, but can I ask you to explain what information should be shared with patients when they're being diagnosed, how that should be done, and where patients should go after first diagnosis in terms of their HIV care?
So I think it depends. We've got two approaches we put in the report. The first is, David might want to speak to, if somebody receives a new diagnosis outside a specialist setting and what happens in a specialist setting. And ultimately the information is going to be the same. It's the pathway in, I guess. However, I think what I would want to preface everything with is that information sharing and for people learning about what's happening is a process. There won't be a moment when you know everything or you know nothing. It will be a continuing, ongoing discussion over often many different conversations. So this is a process for people to be able to have all the information that they need. But maybe if we were to say what would be happening to somebody who might have a test in a primary care setting, and where we would begin.
Yeah, so testing in primary care is more common now than it used to be. There was almost a desire not to test at one stage. That has changed. So now we will be testing in appropriate circumstances. And sometimes the result can be a surprise when it comes back, or sometimes people are more prepared for that. So what will simply happen is that you would try to see the patient, arrange an appointment for them to come in and chat them through. And I think in primary care you'd be giving them very basic information, assuring them of the support that any good primary care team should provide with any condition. So we're looking to provide care, understanding, respect, excellence insofar as that is provided in primary care. But I think the key thing is communication and assuring them that you're talking to their secondary care team, their specialist team, that they will be referred on. Hopefully they'll get a timely appointment to be seen. You give them advice. I think the key thing is also explaining that this is something that obviously will be a bit of a shock to them. If they do want to come back and have a chat with you, if they have any questions, often informing patients that it's entirely appropriate to write a little list. Often doctors are thought to hate lists, but in these circumstances, come back with a list. These are the questions that you may want answered. And then offering to see them after they've seen their specialist team, because often they go and see the big doctor, the specialist doctor in the specialist centre, and that can seem quite daunting, and they will have questions because the experience can generate questions that can quite simply be answered in primary care. And also increasing with specialist teams being at a distance, then there is much more that can be done in primary care in terms of follow-up blood tests and so on, so that people don't have to make onerous journeys to have very basic tests done that can be done in their local setting. So it's facilitating the care and ensuring that patients know that they're on a sort of continuum of care and we're all on the one side trying to support them. I think that's what good care looks like now.
And out of that arises a couple of issues, one of which I know you're dealing with in the supplemental letter of instruction, but what you're describing requires those that are delivering care in primary setting to have some knowledge of HIV,
Yes.
And to be able to impart that to the patient.
Yep.
And you're going to be dealing with what training and so on medics working in those settings should be will have in the letter of and supplemental report.
Correct, yes.
So again, sorry, do you want me to comment on that? In
Yes,
terms of
please do.
Primary care, I mean, the number of patients with HIV in any individual GP's practice will be relatively small. So again, as a GP, you will go and perhaps just check what's available in your local service. You may even speak to the specialist team that you're going to be referring to, because I think satisfaction equals performance minus expectation. And if you say to somebody they're going to get an appointment in 2 days and they don't get it for 3 weeks, then they're feeling anxious. So you want to find out what you're offering them. And also I think we would refer them to good sources of information, because people, as soon as they get this nowadays, of course, will go straight onto the internet, and the sources of information that come up aren't always just the most authoritative.
The other thing that comes out of there is the referral to secondary care. Professor Anson, maybe you want to pick this up.
So there are national standards. Essentially, in any service where HIV testing is being carried out, wherever it may be, there needs to be a clear mechanism and a pathway for people who test positive to move into the appropriate care that they need after that. And that might be from primary care, it could be in community testing settings, it could be in a variety of settings. But the national standard is that everybody with a new HIV diagnosis should see a specialist team within 2 weeks. If they have any symptoms whatsoever, that should probably be within a couple of days. And if somebody is already in hospital and is having an HIV test as part of a workup for a medical problem, the team with responsibility for HIV within that hospital should be seeing that patient within 24 hours. So those are the national standards that the British HIV Association has set, and we would expect people then to be working within those confines. Now, obviously, if somebody has an HIV test within, for example, a sexual health setting, they may actually be immediately able to meet somebody, and increasingly with point of care testing, you may find somebody who is having a test who is able to go straight from having a finger prick test, which is positive, to meeting a specialist team potentially within hours. So it depends a little bit on where testing is done, but the bottom line standards are 2 weeks if you're well, 2 days if you're not, and 24 hours if you're sick.
And to a specialist team. So why is it so important?
So a specialist team, and by that I'm particularly talking about a specialist team, because you won't necessarily meet a consultant immediately or a doctor, but the team will have that specialist knowledge. So often the first person they will meet will be a specialist nurse who would be able to assess where people are at, because actually often some of the questions that people have require a bit more information than just a positive test. So to actually find out, start to take a full history and examination, work out more information that's going to be able to inform the process going forward. So meeting a team of people who've got different skills, and the majority of HIV care now is delivered through multidisciplinary teams. And we would also hope, and it's not universal, we'd also hope that very early on, and I'm not going to say exactly how quickly, somebody who has a new diagnosis of HIV would meet somebody else who's living with HIV and would be able to engage not only with professional expertise but with lived experience expertise as well.
So this was what you referred to earlier, the peer support, and the
Yes.
importance of that in
Yes.
getting people to understand the importance of taking medication and coming to terms with their
Exactly.
diagnosis, etc.
Exactly. And a specialist team, because, and I think we've alluded to this before, we know now that the best outcomes, not only for the person but for public health as well, are to be starting therapy relatively quickly. And so having that specialist advice very early about what's available, what you might choose to take, what drugs would suit you best, when you want to start, do you want to start, how's it going to work, that's quite specialist information, but it needs to be given quite quickly. So it's really important that people have access to high quality, up-to-date specialist knowledge about what is best treatment for them, which will allow them to have the best outcomes.
And then the wider issues that arise with an infection like HIV, transmission to partners, children, etc., the psychosocial impacts and so on. At what point do those get picked up? And again, what specialist skills are required in order to give patients care in respect to those issues?
So again, I think it goes back to what I said at the very beginning. This is about a process, and there will be a multidisciplinary team with a variety of skills, and actually people will probably need to meet a number of different professionals, either as a team together or one-to-one separately. But nonetheless, it is really important that expertise is available quickly, but it may need multiple conversations before you cover absolutely everything. So I think at the very beginning, people usually want to know, okay, I have HIV, what stage is it at? Am I ill? What's going to happen? What treatment shall I start? Those are the sort of, I guess, the immediate things. But actually, the next question is, well, what sort of relationship are you in? Are you having sex with somebody? What are you going to do about, what do you want to do about telling other people? And where does that disclosure lie, and how does that happen? There are specialist health advisors within sexual health clinics, and the Beaver standards recommend that everybody should have the expertise of somebody to talk about how you might want to have the conversations with significant others, including family members, and to start to think about children as well. But those are big conversations. They don't happen in your first half-hour appointment. They are going to evolve over a period of time. Normally, within our clinic, and I think most clinics, somebody with a new diagnosis of HIV would be allocated about an hour of clinic time, and during that time would have probably a confirmatory test. They would have tests taken for CD4 count, viral load, other baseline investigations. They would rarely be done in primary care, although they might be. So not only would you be sharing information, you'd probably also be gathering information at the same time, and then trying to piece the jigsaw together over subsequent visits.
And then once that initial prescription of medication has taken place, what does the care look like from then on in?
Well, I think, first of all, I wouldn't say that initial prescription. I think you have to, first of all, think through, you've heard from Ian, there are now multiple drugs on the market, multiple combinations. We have national guidelines. And there are alternative regimes that people may start. And also, the idea that you're going to have a blood test one day and start treatment that's going to be for the rest of your life, the next day, it's a big step. So often you may want to have some time it might even be the first few appointments, thinking about what it means to start treatment, which is the best regime for you, which mixture is going to work best, coming back with questions. So although increasingly people are being treated very quickly, and in some clinics people are being treated on the same day, I think normally people would want some space. So I don't think yet, and I'm not going to say this is yet the norm, that most people would probably leave their first visit with treatment information, but not necessarily a prescription. And that prescription for some people may not be for some time yet. Now, obviously, if somebody has got very advanced infection and they're very sick, or they're in a hospital bed, then things are going to move in a different way. And I would also reflect back that if somebody's got primary infection and a very high viral load, then that might be another indication to move very quickly with antiretroviral therapy. But actually, most people will want, you have a lot to digest, as David was saying, and that requires processing before you go out with a prescription. So the first few visits will be dependent on what the person needs. There'll be perhaps visits more close together, where blood test results taken on visit 1 will be discussed a week back or so later. But it will not necessarily be all the same in one package for everybody. I don't know if that resonates with your
No, I was going to say
or...
there are a couple of things. If someone's diagnosed with advanced disease with an opportunistic infection, actually it may not be safe to start antiretroviral therapy.
Actually, that's a good point, yes.
Straight away, because starting antiretroviral therapy improves the immune system, and people can get what's known as immune reconstitution syndrome, and people can be unwell. So, for example, in patients presenting with TB with advanced disease, we treat the TB first and then start the antiretroviral therapy. The other thing I think which drives often why people want to start therapy immediately is because they're concerned about onward transmission to others. And that is often a big driver wanting to, they're concerned about their own health, but they're concerned about the health of their partners and such like.
And then once one's got over the initial stage, then what does the care look like? Is that delivered in specialist centres on an ongoing basis, or do you discharge back to primary care once the viral load is
So for most adult patients, let's assume, excluding somebody who's very sick and in hospital with complications or has got an opportunistic infection, the initial period, probably a number of weeks, and I'm not going to be more specific than that, where the assessment, the baseline tests are done, a treatment plan is considered and things start to move forward. If somebody starts antiretroviral therapy, you would want to see them again at least 2 to 4 weeks later, so that you're able to see if the medication is suiting somebody, how it's going, checking in. Often there would be a phone line or a nurse or a pharmacist who you could talk to as you start treatment, as you go through. Most people would have met a specialist pharmacist before they start treatment to help with adherence. And so that period of starting treatment will require different amounts of support from different people, but it would normally be happening in a specialist centre. And then once somebody is stable on their therapy, by which I mean they are happy with it, and it is working, the viral load's going down, you would see them less often. But once the viral load is completely undetectable, you'd be starting to think about even 6 monthly appointments. But it will depend on each person individually what support they need in that first bit. But that will nearly always happen within specialist care with, if somebody has been tested in primary care, liaison with letters, assuming the patient gives consent for that to happen.
Just one very quick point about the small kids. When we start antiretroviral therapy on very young children, because their weight is changing and the drug dosage is dependent on the child's weight and their growth, we see them very frequently. We'll be seeing them, I mean, if we're starting under a year of age, we'll probably see them once a month. And then only as their growth stabilises out can we stretch those appointments out a bit more. But I mean, most of my teenagers we're seeing maybe 3 times a year in school holidays, typically.
Mm. And I think there's also a sort of interesting phenomenon. If somebody has a new HIV diagnosis, a lot of other worries may come up. So something which before they had an HIV diagnosis they might have dismissed as a minor thing and not been worried about, may become a much bigger worry. And, oh, is this a sign of something? So having the availability of a phone line, somebody to be able to come in for an extra appointment if worries emerge is also very important. But that, again, would usually happen in a specialist setting.
The targets for referral on to specialist secondary care are short, ambitious ones. Are you aware of any resource funding issues nationally which affect the provision of services or care or treatment for HIV?
Well, for the moment, HIV treatment and care is free for everybody who is resident in the UK. And that's absolutely clear. So there should be no barrier for people to be able to access specialist care on a financial basis, and nobody should have to pay for that. However, I do think it's important, I would defer to David here, how to access if the nearest specialist centre is an hour and a half on the bus. How do you want, there are actual physical access barriers, which I think are important. And I think there's also the disconnect, if you like, the way the funding flows, which is a bit more complicated. The money is there for specialist HIV treatment and care, but that's different budget from some of the other care that people living with HIV might need. But in the short term, there should not be a financial barrier for anybody having the HIV care that is appropriate for them.
Just quickly, it is a self-referral, so you don't need actually a GP referral.
Yeah.
So people can attend any centre they want, which is
And that-
unusual
yes.
for compared to other conditions.
And that's really important. So the choice of where you might choose to go is also open, and the ability to go to either somewhere near where you work or where you live is in your hands. You can choose.
Can I just add one thing that we wrote in the report as well, is that these centres and all the conversations that Jane just said, it's not just even the patient, the families or significant person in somebody's life is very much part of this decision making, and we wrote this, if somebody wants to bring their partner, their child to this consultation, that would be encouraged as a sort of holistic way of caring for somebody with HIV these days.
And one of the questions that's been left over to the supplemental report is what is the optimum level, what is the optimum model of care for somebody with HIV? And you're going to be addressing that in the supplemental letter.
We are going to be addressing that. I think in summary now, though, we can say that it needs to be person-centred, coordinated, joined up,
And integrated.
and integrated with all the other things that are happening for somebody. And we will go into that in more detail.
That was the end. Comes to the end of the questions that I had. I've got a handful of questions from core participants. So why do some people not contract HIV when exposed to the virus through blood products or blood transfusion? I think we addressed this briefly.
I think we addressed this this morning to some extent. So it's a balance between the exposure risk, how much virus might be in whatever exposure there is, balanced with the susceptibility an individual might have, which might vary, partly for genetic reasons and partly for other reasons. So those factors into play.
Is it possible for somebody to clear HIV?
2 cases.
Yes. No, there are people who are known as elite controllers who effectively, through their immune systems, they are able to control, and they may well have an undetectable viral load but not on treatment, and they're at the another end of the spectrum. Right. There have only been 2 cases of people who have eradicated HIV, usually through stem cell transplantation for treatment of relapsed lymphoma. And this comes down to the using stem cells which don't express CCR5, which is what we alluded to earlier. Those stem cells mature into the new immune system, but they are no longer can be infected by HIV because they don't express CCR5. So there is a patient in Berlin, well publicised, called Mr. Brown. And there's a case from the London clinic, the clinic that I work at, which was publicised in February last year.
So we have a section in the report about cure, and I know it's a common question for patients in clinic continually, and that's part of the answer to that, is that in theory it can be possible in a very small number of patients to have cure, but it relies on quite extensive chemotherapy, which can really only be justified when you have another reason to have it, in particular cancer. So the cases Ian describes are both cases where patients needed chemotherapy and then had to have a bone marrow transplant. And so one of the research areas at the moment is to understand how that process could be done for more patients safely. And at the moment, we're not in a position to be doing that.
And just on the question of cure, yesterday when evidence was being given by the hepatitis expert panel, they were talking about curing hepatitis C. So what is the difference between HIV and hepatitis C? Why is it HIV can't be cured?
So it's partly, as we were discussing earlier, this is a virus that integrates into the host DNA and can also pass between cells even when therapy is effective. So trying to get rid of that virus completely from the body is very difficult, and it requires at the moment this quite radical approach to try and do that. And even in these 2 cases, and these are well publicised, they're undergoing close monitoring still because we don't really know the durability of these procedures when they happen. And Timothy Brown, I think it's been over 10 years now, but the most recent case is less than 2 years. So we're still learning what the durability of that could be in terms of whether the virus could come back. We think probably not, but we don't know.
And you mentioned elite controllers. Did I understand from your report that even elite controllers will, if they don't have treatment, the viral load will lose control of the viral load ultimately?
Not necessarily, although a proportion will do. But there is a group of patients who appear to have an antibody response but don't have virus that re-emerges, or at least hasn't yet.
Yes.
You just asked about Hep C, though, in terms of what's the difference?
Yes.
Yes. So hepatitis C doesn't have that process as we discussed yesterday, where it would integrate into the host DNA, for example. So it's possible to eradicate the infection completely from the body more straightforwardly than it would be for HIV or hepatitis B, in fact.
Are the risks of infection in blood products and blood transfusions greater than exposure to the virus in other ways?
The answer is yes.
Yes.
We talked about
Why?
that
Yeah, we
earlier.
took-
Yeah.
Well, it's a larger inoculum. I mean, and also it's directly given into blood. So if you're looking at the sexual transmission, it's an inoculum within genital fluids, and the amount of HIV is going to be smaller compared to a blood transfusion.
And you will sometimes see that quoted as 100% risk. I think for reasons we've discussed, it's probably not that, but some of the reference texts that we've looked at do actually use that sort of level of risk.
Does the fact of co-infection between HIV and HCV or HBV mean that so I think this is, I think evidence was given, I asked a question about whether or not the fact of co-infection between hepatitis and HIV alters the natural course of HIV, to which the answer was no. And the question that's asked is, does the fact of that co-infection, which means that the immune system is fighting the HIV, mean that in fact the patient is impacted indirectly? So the immune system is having to do more. It's on the treadmill, having to run twice as fast because it's got hepatitis and it's got HIV. So is it impacted in that way?
I mean, in a sense, it's difficult to be clear about that, but certainly in terms of the sort of activity we talked about before, then the exhaustion and the weakening of the immune system has consequences for the control of other viruses as a result of HIV, and that's both true for hepatitis B and for hepatitis C.
And a similar-ish question, does the fact that someone is infected with HBV or HCV give rise to a greater statistical risk that they will also be infected with HIV?
In general, yes. It depends very much on the routes of exposure and the risks and the geographic location. But there are many shared routes of transmission, so overall there is an increased risk. Yeah.
And we would also say that hepatitis B and hepatitis C would be indications for an HIV test. So it's really important.
Absolutely, sort of everybody with either of those infections needs to be tested for HIV, and potentially more than once if there's ongoing exposure risk.
The virus HHV8, which causes Kaposi sarcoma, is that transmitted via blood and blood products?
So I'm not sure that's something we've looked at this point.
It's largely transmitted sexually.
Yeah.
So that's the reason why it's much more common in men who have sex with men than in other affected patient populations.
And it
It's
can
something we can certainly comment on.
It can certainly be transmitted perinatally as well, HHV8.
It's a very common African thing.
We can explore and put into our supplementary report any data that we find.
There are some questions that are of particular interest to women with bleeding disorders, and they are this, that the inquiry has heard evidence and they experience more blood during menstruation, and also so there's more blood on household items and more blood during intercourse. And the questions that arise from that are, is there a higher risk of infection for those individuals through sex because there's more blood present?
If people are living with HIV with an undetectable viral load, it should make no difference. Graham, would you agree with that?
Yeah, and then I think in the setting where people aren't on effective treatment, it's hard to say. But generally, where there is more blood during sexual intercourse, we would imagine there would be more transmission. I don't think we have very good data on that.
I don't think there's very much data at all, but nonetheless, a woman who is on effective therapy should not be worrying about a sexual transmission during menstruation.
And equally, the concern about there's more blood around generally in their life, and so more blood on household items and so on. Is there an increased risk of infection to family from blood on household items?
No, I don't know.
No.
Reiterate, it's the viral load.
It's the viral load
It's
that
the
matters.
viral load.
Yeah.
If the treatment, which everybody should have access to now, is effective, viral load is undetectable, whatever circumstances we're talking about will be the same answer.
Yes.
So these questions, as I understand it, are concerned with the historic position, so before effective treatment, where the viral load was undetectable.
Very
So I
different.
think we haven't addressed issues in the report here related to specific haematological conditions, and I think
So perhaps those could be asked tomorrow of
Yes.
Professor Rockström.
Yeah.
But we know that the presence of blood that contains HIV can be transmitted to another person if it is blood-to-blood contact
So during sexual
or sexual
intercourse. But
intercourse.
in terms of household outings
Yeah.
or looking after somebody with HIV, no. If people take precautions, if there have been reports of someone who's a carer who has acquired HIV through handling infected material from a patient, but that should not happen in terms of with universal precautions.
So one of the other questions that they ask is how long does the virus live outside the body?
Very short.
Short.
Very, very short.
What does that mean? Seconds, minutes, hours?
But it doesn't, effectively, when you're talking about viral transmission, if you have blood on a kitchen table, even if it did live for 2 hours, you've still got to get it into a bloodstream.
It's got to be exactly.
You know, so what you've got to think is the issue about inocular.
Yeah, the inoculum, but also often transmission occurs through cells. So cells are responsible for, because the cells that are infected with HIV, it gets transferred across to and cells will die very quickly outside the body in blood.
I know. I think it's worth mentioning, though, that we may be talking in domestic situations where, for something like children who had haemophilia, who were bleeding, and I know that the bleeding is often joint bleeding, but something like profuse nosebleeds, which really are very, very profuse. The concern around a parent becoming infected from a child with HIV is a very real concern before we're talking about treatment. When the idea of HIV in the blood is up there, that's a very real concern for people.
Sure. Can I add? It was a very real concern, but actually the data as it emerged became immensely reassuring. That there were, as far as I'm aware, absolutely zero transmissions to people caring for HIV-infected youth. That's not true for hepatitis B.
I was going to say hepatitis is different.
And so another question they ask is, would standard washing procedures destroy the virus? So we're talking about the blood on the table, wiping it away, that would get rid of the virus.
Yes.
Absolutely.
Then questions about treatment. Were there any additional side effects of HIV treatment? And I think here we're talking about the older treatments for those who were co-infected with hepatitis C.
there were, and we also saw additive side effects from having combinations of treatments that would be potentially problematic. And in the setting of inflammation in the liver, that often one of the more common side effects we haven't really touched on is inflammation in the liver as a response to drugs. And in the setting of where there's already inflammation, that can be exacerbated by the addition of HIV medication. So that's certainly something we recognise. And in general, patients who have co-infection with hepatitis tend to have more side effects from the same medication.
And is there a link between Truvada and kidney infection?
not kidney infection.
Not infection.
But one of the drugs in Truvada, Truvada is a branded name. It contains emtricitabine and one of the early versions of tenofovir. And tenofovir can have, as a side effect, can affect a part of the functioning of the kidney and cause kidney renal toxicity. But it's something we monitor for.
Yeah, I was going to say people are monitored for all of these side effects very regularly.
So, but it's not related to kidney infection.
No.
And another question about AZT treatment. The question is, why would someone not have been given it? So were there any clinical contraindications for being prescribed AZT in the early days in around 1987?
Well, in 1987, it was given to people who were ill with AIDS and people who had symptomatic disease. So if someone was HIV antibody positive but otherwise well, there wasn't any evidence that giving AZT to those patients would have benefited. So it's largely targeted for people who were had life-threatening illnesses and infections. But if, for example, someone had severe anemia, then many people have thought about giving AZT because AZT can cause anemia.
And actually there was quite a prominent and very disappointing trial called the Concord trial, because we'd seen these improvements in life expectancy in people who were very sick. A trial was put into place to see if it would help people who were less sick, and the results showed that it didn't make a difference. And so that was where the decision-making came from about it being used in sicker patients at that stage.
And the side effects of AZT in the time many people, it had a lot of bad press. And lots of people, there was terminology around at the time, you know, it was the AZT that killed you, which obviously was not correct, but people died despite being on treatment. And so for some people, they felt strongly they did not want to go on this drug, and some medics would discourage it because of the
Toxicity.
fair comments around about the toxicities and the side effects.
And that's another question, is what is known about deaths being caused by that treatment?
I think, in terms of what is known, as I was saying, a lot of people felt that, or it was put about that AZT was causing the deaths, but it wasn't that. It's because AZT effect was transient, and therefore it only had short-term benefit, and therefore people relapsed and went on to become ill as a result of their underlying HIV, because the effective treatment with AZT was very short-term. That's not to say, for example, someone having AZT and becoming anemic did not, have side effects from that. But I mean, there have been deaths associated with antiretroviral therapy. For example, some of the non-nucleosides can cause very severe rash, Stevens-Johnson rash, which can result in really disquieting rash and a severe hepatitis, and people have died as a result of that. But I think there's
a sensitivity reaction
to
abacavir, reaction, which was rather specific and genetically determined.
Yeah.
But I think, I mean, I remember very clearly coming back from the States in 1994, full of enthusiasm to use AZT to try and prevent or decrease the risk of mother-to-child transmission, and finding my colleagues being vilified for using AZT because it was regarded at that moment in history as a poison, and that was an echo chamber that led to people demonstrating outside Great Ormond Street Hospital, accusing people there who were very well-meaning physicians, paediatricians, trying to do their very best to help, being castigated as murderers. I mean, it really was a very uncomfortable time.
I think it's just worth emphasising, we've touched on this, but it's worth emphasising because there was so much recognised toxicity with AZT and those early treatments, they did tend to be left until they were really needed at a late stage. And so there was often quite a close association in time between starting them and death. And I think it's quite understandable how people became concerned that they were causing deaths, but generally the evidence didn't support that directly.
Excuse me, I've got one question on my phone, so I'm not just reading my text messages. So this is a question in relation to the evidence that you gave about the immune system remaining hyperactivated and not
Yes.
returning to a resting state. And we
Yes.
a very, very visual image of being on the running machine. So the question is, what effects would this hyperactivation have on the autonomic nervous system, and what kind of cognitive, psychological or physiological consequences might that have for the patient?
Well,
And what might modulate those consequences?
well, I think there are a couple of things there. One is that immune activation is a feature of untreated chronic infection, and that leads to release from the immune system of lots of cytokines, which produces inflammation, and that's bad, generally bad. In terms of the autonomic nervous system, definitely like the peripheral nervous system and the central nervous system, it can be affected by HIV. Neurons are not directly infected by HIV, but the support cells that support those neurons are. And so people can get an autonomic neuropathy, as well as getting a peripheral neuropathy. And so the features of an autonomic neuropathy would be dizziness when you get up, or a fast pulse rate and things like that. And we do, and certainly those are features that we have, I have seen in patients with HIV. In terms of cognitive, it comes back to Graham's description of HIV in the brain. And so the drugs how drugs get across the blood-brain barrier may be different, but definitely if you look at HIV in the brain and the people who died from HIV definitely affects the brain in terms of the support cells and results in loss of neurons, and can affect people's cognition. There's no doubt about that.
And I agree completely, but I think the direct link between inflammation and those two things, I think, is less clear, although those two things are definitely recognised complications of HIV and its treatment.
What is the norm to do? Is it the norm to do autopsies on all HIV deaths? And if so, when was that the norm? And does it remain the norm?
It's no longer the norm. There was a time, I think, early in the epidemic when there were a lot of very important and unanswered questions, and people would die without us understanding why, and we would ask if we could ask for an autopsy to understand better. I think now I think there are fewer, but there was a period of time when there was a real uncertainty about what had happened and trying to find out.
And I think it differs slightly from centre to centre, but I think generally there is an ambition still to do autopsies when the cause of death is unclear.
Absolutely.
And partly for the benefit of learning and knowledge, partly for the benefit of family. And there are still conditions that are emerging that we still need to learn about. So it's definitely something that's often requested, although I think actually progressing to autopsy is less common than it used to be.
What is known about the prevalence of HIV infection in first of all, the United Kingdom UK population, and secondly, the UK blood donor population since 1970? Are you able to answer those questions? Is the first.
I know the hemophilia.
I don't know the data of the blood donors, so
Blood donors.
Since 1917.
So the UK population and the UK blood donor population.
I think we have a figure in the report, and I think the figure quoted here is 0.67%. Oh no, sorry, that's hepatitis C. There's a figure in the report, I think, if someone can find it.
the thing about, I think I would emphasise here is the prevalence of HIV is very variable across the UK. So there are areas where the prevalence is high, and that is considered to be greater than 2 per 1,000 population. Areas where it's very high, where it's greater than 5 per 1,000 population. But if you take the generality or the average across the UK, then that's lower. But I think what's important is looking at each particular area, because things change very dramatically. The centre of London is quite different from a rural population outside London, for example. So there are some very clear prevalence diagrams from Public Health England where the exact prevalence can be seen. And I think those will have been mapped. I'm not sure they've gone back from the 7th. I think it would be, we'd have to look back. I think their records began in about 88, 89.
Yeah.
But Public Health England are the guardians of that data.
So I think the figure we have in the report for the prevalence in first-time donors is 0.03%, and I just need to check that because I think there might be a typo in the report, which we'll check in relation to HCV, but that is, I think, the figure for HIV.
And in terms of just going back to the prevalence, in our supplementary report, we've been asked some very specific questions on data sets, what's known, where it is, and we'll put this into there.
Yeah, I mean, the other source of data is from the National Surveillance of HIV in Pregnancy and Childhood, and the NHSBC. There's a website that is very easily accessible that documents all of the seroprevalence rates. And as Jane says, these vary considerably across the nation.
Just 2 more questions. Do you know what the death rates are for babies infected perinatally? So those that would have been infected perinatally.
Well, yes. I mean, I can tell you the death rates from cohort studies for the perinatal cohorts in Europe were published, natural history data modified by a little bit of AZT use, but published in about 1996, showed that 15% of the perinatally infected children were dead by the age of 6, whereas the same analysis performed in Malawi showed that 15% of the children were still alive at age 3. So again, it comes back to all the other comorbidities that children around the world with HIV are facing. But in Europe, the overall survival rate was about 85% at the age of 6.
And are you aware of any studies on the infected blood community, so those that have been infected with HIV through blood and blood products?
We are, and we have referenced those in the report, and I think tomorrow you will be able to get more detail from the team, the expert panel. We have put this in.
We can pick that up tomorrow.
Yes, I think because the author of that particular point will be on the panel tomorrow.
Okay. And the second part of that question is: are you aware of any studies on the stigma on those living with HIV for long term, the consequences of that, and in particular in relation to stigma? The long-term consequences of living with HIV.
As whether people experience more stigma or less stigma, or the impact of stigma in the long term.
Yeah. May I just turn behind me because I'm not quite sure.
Your study. There's a stigma survey every year, isn't there? Or is it in Australia?
We can try and answer it both ways around.
I think there are 2 parts to that second part of the question. So I think studies on stigma in HIV and studies on the long-term consequences of living with HIV.
So the long-term consequences of HIV, there are a number of studies ongoing at the moment, and I think there's a couple with particular relevance. One is called the POPPY study, which is looking at people who are both older with HIV and people who are older who do not have HIV. And the data that's coming from that is able to have a very close look at the differences between people who are living with HIV and getting older and the people who aren't. And data is coming from that study now, and that's being coordinated by Imperial and UCL. In terms of stigma, there's a lot of work going on. I think one of the things I would say is that we are very well aware that HIV-associated stigma remains one of the key blocks to long-term good health because of some of the things we've discussed. We know that people are still not taking HIV tests early enough, and so we're seeing ill health from late diagnosis, which is associated with stigma. We know that people are avoiding medical care, so stigma is having a direct impact on well-being.
And one of the things we were discussing outside was that I think as HIV is seen less as a public health crisis and more as a chronic infection, increasingly in elderly populations, it's getting harder to motivate for resource for the kind of studies that will answer those questions. So we've seen a recent example of where funding has ceased for the big UK cohort study, which gave us a lot of this information.
Those, I think, are the end of the questions that I have. But can I just turn behind me to see if anything arose after the break? No, I don't think so. No further questions.
Well, there's no question from me. When you were talking about advising someone about their infection, you described the advice and learning it as a process. I have to say that you collectively have contributed very much to what has been a process of learning for me. It's part of a process. No way have I finished. But I must thank you very much for that. You might like to know that in the breaks, a number of people have been speaking very highly and entirely correctly so, in my view, of the expertise and the empathy that you have shown. One of them described you as a fantastic group of experts. Another said that they were very grateful that they felt that you had, in what you had to say, acknowledged the symptoms which they have lived with for years, something which plainly is of real value. Can I thank you for that, besides thanking you for having made the time to come here and share your expertise, and indeed to give yourselves the task of going on to answer the supplementary questions and be available for any further expert advice that we may wish from you. Thank you. Well, it's 10:30 tomorrow, and we will be examining bleeding disorders, will we?
Yes.
So 10:30.